Hello, everyone. My name is Gabriel Petit. I'm a neonatologist at the Montreal Children's Hospital, and today will be my pleasure to present on targeted agents reducing global hypoperfusion in extreme preterms. I'd like to thank the organizing committee for inviting me for this talk. These are my disclosures. So the objectives today would be that at the end of this session, the participants will be able to describe the physiological concepts underlying perfusion and shock in the context of prematurity, as well as discuss some of the literature supporting approaches to management strategies in shock and prematurity. And initially, when I was asked to present on this topic, I felt like this, but told myself, you know what, let's bring some chillness to this, and hopefully by the end of the talk, we'll all feel a bit more like this. So I started with a non-scientific approach to the talk and decided to survey the Twitter community, where I presented a case of a newborn at 25 weeks who was at 24 hours of life on CPAP with low oxygen support, who was active pink with good refill and good heart rate, but who had trending numbers of mean blood pressure going down. And it was very striking to me to see that many of you responded, and maybe it's a biased sample, but that many of you responded that you wanted to get more physiological information about this patient before your next steps. When I took the same case and actually introduced the concept of being gray, clamped, cold, which are signs to me that, probably there's some disturbances in perfusion. You can see that many of you did respond that you wanted to get more physiologically based information for this patient, while some of you did mention that you would introduce some cardiovascular medical support. So when I'm tackling this question, I'd like to tackle the idea that we should be targeted, that we want to reduce the burden of global hypoperfusion, and that there's particularities to the extreme preterms. And so I did ask ChatGPT what they felt about this title, and they provide me with exactly the same breakdown, that we should be targeted, which means that we need to have specificity in terms of the pathways that we're addressing to minimize side effects and maximize therapeutic benefits. That we want to reduce the global hypoperfusion, which refers to the inadequate blood flow to the organs and tissues of the body. And so global implying that there's issues with multiple areas or the entire body. And that extreme preterms are particular because they have profound immaturity of their organs and body systems. So I felt, you know what, let's go back to step one, which is the physiology. Many of you will define shock as, tissues that are not receiving adequate supply of oxygen and nutrients to meet metabolic demand, which leads to this state of ischemia and dysfunction, and eventually leading to necrosis. And that perfusion is the matching between this oxygen nutrient delivery towards meeting metabolic demand. And so at the bedside, we obviously have this internal kind of mechanism of going through the bigger picture of our patient. And we often use blood pressure as a correlate to some of the perfusions in some of our organs. And I want to remind ourselves that pressure is a function of flow and resistance. And that when we look at a system, blood pressure is often the function of the cardiac output from the heart that is generated times the resistance in that particular system. Now, if we look at these different components, first of all, we know that blood pressure tends to be pulsatile with a systolic phase in contraction and a diastolic phase, which is influenced by the competency of the valves, as well as the tone of the vascular system that we're analyzing. There's influences about how we're measuring it and where we're measuring it. And we often use the mean blood pressure as a way to translate the entire complexity of the waveform throughout the cardiac cycle into the area under the curve of this pressure to give us a sense of what's happening at the bedside. We also know that the pressures and the resistance and the outputs may not be similar into the lungs as well as into the rest of the system, and that in the premature infants, there's obviously connections that are persistent in many of them that may influence through pressure transmission or volume transmission. When we look at the component of cardiac output, which is often a function of stroke volume times heart rate, well, we know that the stroke volume is profoundly influenced in the context of prematurity. It is influenced by contractility, preload, and afterload. And we know our preemies have myocardial immaturity. They're exposed to certain medications, as well as sometimes a component of asphyxia. That the preload of the left ventricle is very dependent on lung perfusion, which is impacted by some of the cardiorespiratory interactions and hyperinflation. that the preload is influenced by the capacity of their left ventricle to fill, which we know that they run typically at a faster heart rate, which decreases filling time, and that they have smaller ventricular sides, which had a tendency to have more hypertrophy and stiffness. We also know that heart rate is influenced by some of the maturity level of the autonomic nervous system, of the hormonal control and hormonal response, as well as to some of the chronotropic medications that we do give at bedside. And so the initial case that I presented, when you're actually trying to get more information by combining some of these non-invasive metrics like echo, may be able to help targeting some of those phenotypes. So for example, maybe this patient has completely normal ventricular function or normal filling, but maybe this patient has a very profound cardiac dysfunction with both the right and the left ventricle having almost a standstill in contraction. Maybe these patients have significant preload issues with very low filling of both the RV and or the LV, which leads to low cardiac output. Or maybe there's like adverse cardiorespiratory interactions with some of these patients having a profile of acute pulmonary hypertension, leading to right to left shunting at the PAD level or to compression of the left ventricle by a struggling right ventricle. And then finally, although these are rare, some of these patients may have elements such as tamponade, which may restrict the filling of these ventricles. When we look at resistance, obviously total peripheral resistance is the sum of all the local resistances. And we know that autoregulation in the context of prematurity may be influenced by the level of maturity of some of these organs, as well as the response between these organs. We know that also some of our preemies are exposed to inflammation from choreo or from mechanical ventilation, from oxygen, that they have exposure to steroids that may impact this, like vascular stiffness, medications, or even placental dysfunction. We know that viscosity may be influenced as well as filling in terms of the late cord clamping or polycythemia in the context of growth restriction. And we know that these systems have a tendency to be connected, which leads to situations where you have shunts that may pressure transmit or volume transmit, and that all of these shunts may eventually impact the resistance of the system against which the left ventricle, for example, might be pumping because of the transitional physiology and because these shunts may not be created equally. So some of these babies may have, very large shunts, which leads to kind of retrograde flow in many of these organs during the diastolic phase and a steal into the pulmonary circulation. And the impact of this on perfusion, especially in the context of pathological events, is very understudied. Now, we've listened to Dr. Moore, who spoke about the tight control of the cerebral vascular autoregulation. And we know that prematurity may influence how autoregulation is in the brain, and that a lot of the interventions that we do in the context of prematurity, including exposure to vasopressors and inotropes, may influence this. Now, if we go back to some of our landmark textbooks, Dr. Rudolph in Congenital Disease of the Heart did address a bit the postnatal circulatory changes in the preterm infants. And what he mentioned is that it was suggested that blood pressure can be considered to be normal when the mean is equal to the gestational age, but that actually this is very arbitrary and has not been confirmed from any reliable observation. He also mentioned that little information is available about this postnatal circulatory changes and that there are no established actual standards of actual pressures and how these pressures may not actually relate to the blood flow in some of these organs. And so what do we have in terms of data? I went back and I looked at shock, prematurity, and newborns in the context of trials. You can see here 16 results, which is great. And many of these results are not reliable. They're not talking actually about the management of shock and prematurity. But we'll try to go over some of these RCTs that were done, tackling some aspects of shock, many of which are based on blood pressure measurements. The HIP trial actually tried to randomize patients based on blood pressure to dopamine and placebo. They were unable to get the planned recruitment. They only had 8% of the cohort and actually found no difference between the two approaches. This group looked at volume repletion only and found that volume repletion will increase your blood pressure, and probably saline is as effective as albumin. And this group actually recently published on septic shock in the context of refractory management after fluid, after catecholamine, and found that methylene blue, which is really a drug that we rarely use, led to quicker increase in blood pressure. Whether this translated better perfusion or outcomes is unknown. Now, we've talked about dopamine, and we know that this is one of the most studied drugs. And so when looking at RCTs, actually trying to quantify low blood flow and studying the difference between dobutamine and dopamine, they found really no difference in blood pressure, although dopamine seemed to increase a bit left ventricular stress. But they found actually that those two drugs were not improving contractility in these patients. They found that when you add hydrocortisone, you may be able to get less dopamine time. They found also that dopamine achieved higher blood pressure numbers compared to dobutamine, but that dobutamine actually achieved better flow than dopamine in some of these RCTs. When we look at later down the road in these cohorts, there were absolutely no difference in the combined outcomes of death or disability when comparing these two drugs. And when recently there's been the Neonatal Research Network to try to do an RCT on the subject, they were just not able to recruit. When we look at epinephrine compared to dopamine, which is another very common drug in the NICU for the management of some of these vulnerable infants, there was no difference in cerebral nears or blood pressure between the groups. And actually, epinephrine in one of these RCTs was associated with slightly higher levels of side effects, such as hyperglycemia, insulin exposure, lactate, and low bicarb, with no difference in clinical outcomes or blood pressure increase. And from the same group, looking at the later outcomes, there was no difference between epi or dopa in terms of death or neurodevelopment. Finally, milrinone is another agent that's been proposed in prematurity. This study was actually looking at prophylaxis of milrinone and found that it did not prevent low systemic blood flow, and there was no difference in blood pressure, IVH, or death, but there was actually a slower ductal constriction in the group exposed to milrinone. So data from RCT are not helping us so much right now. And a lot of what we're going to be doing at bedside is often based on physiological assumptions and observational data, as well as animal data that was previously showcased. And I want to finish the talk by referring to this article, which I think is very brilliant and was written by Dr. Gissinger, which I dedicate my slides to today, who did huge work in the context of shock in the neonatal world. She published this article where she actually fine-tuned and proposed a phenotypic approach to the physiology, which really relates to a lot of the patients that we see with prematurity at the bedside and who have assumed low cardiac output, low blood pressure, or low resistance. There are values to guide some of these abnormal metrics, now putting into the mind that BP doesn't equal to perfusion. And this article really goes through some of these different mechanistic aspects of low vascular resistance and low cardiac output. I'm not going to go through the entire algorithms, but I do find that having an approach at bedside which incorporates multimodal evaluation is probably the best what we have based on the literature and the limitations of trials that have been done in the past on this particular topic. And so she does go through proposed first line and second line based on some of these review of literature. But I think one of the key tables that is quite important is what we currently know from various studies on the effect of all of these agents on stroke volume, systemic vascular resistance, and peripheral vascular resistance. Now, my slides are going to be available, and I've tried to condense this knowledge into a slide which outlines a gradient between what we think some of these drugs are doing, especially in the context of prematurity, to systemic vascular resistance and to support of cardiac contraction. Some of them have a mixed profile. Some of them will lead to systemic vasodilation. But you can see that none of these drugs are perfect, and all of these drugs have side effects, and they're probably very much so understudied in the context of prematurity. And sometimes at bedside is to choose the best poison, to titrate as quickly as possible to get off, and to hopefully do the least amount of harm to some of these patients. There is an ongoing study by Dr. Karad, who presented today at the Hemodynamics Club, and we're looking forward. We're participating to this study, looking at dopamine versus norepinephrine in the context of prematurity. So in conclusion, shock and prematurity remains understudied. I think that premature infants are not small children and they have their own particularities regarding cardiorespiratory adaptation. We know they have transitional physiology, but they also have myocardial immaturity, autonomic nervous system control immaturity, and different responses to some of the therapies that we have. We know that blood pressure is not equal to perfusion and that probably getting more physiologically driven information at bedside is one of the best approach to try to tackle the best therapy at this point. And I'm calling this gentle hemodynamics because I think that in the context of prematurity, the least we do, the best outcomes we get. And the most protocolized approach we have, the best outcome we get. So I do encourage you to have a gentle hemodynamics approach that is selective based on physiological phenotype. It's probably the best we have so far. And that the least we do for these babies are often the best we do for these babies. I think more studies will be needed relative to multimodal evaluation and management approaches, and relative to some of the improvement of what is really meaningful in terms of outcomes to our patient population and their parents and families. I hope you feel a bit more like this and a bit less like this. And I'm open for questions, comments, or insults, and my slides will be available to all of you. Thank you for your attention.